So next, we have Professor Billia, Assistant Professor, University of Toronto, and Director of Research at the Peter Munk Cardiac Center. She's the Medical Director for Mechanical Circulatory Support and the Co-Director of the Peter Munk Cardiovascular Biobank. Thank you for coming.
Thank you very much. I'm from Canada, and I think we've officially made Houston Shock an international program. So congratulations to Marwin and everyone else. And we have representation from Europe, we have representation from everywhere else. Anyways, I'm wasting 15 seconds, I better go on. I have to say, though, that it was great to go after our first two speakers because it kind of set up the stage for what we're going to actually be discussing, which is early versus late MCS support for post-LVAD RV failure. These are my disclosures, not relevant to today's talk. So as was stated, I mean, if you estimate RV failure post-LVAD, it can occur up to 40% in patients. And it's really thinking about MCS and adding that to support the RV. You're obviously increasing the risk over mortality. These are sicker patients, and obviously there's an incremental cost. And when we think about risk of RV failure, you really need to think about clinical factors, direct RV measurement, as well as what happens in the OR. So preoperative patient management is a critical surgical technique, things that can happen intraoperatively, the management through the anesthesia, everything, and things can happen in the OR that is unpredictable. And we have schema that actually define RV failure based on the Intermax criteria, which I've indicated here, mild, moderate, or severe, but really clinically relevant RV failure really is, when we think about it, is the requirement of either an RVAD or inotropic support for more than 14 days. And this is not actually captured by the Intermax definition. And in a more updated definition where the MCS Academic Research Consortium, just a couple years ago, they really broke down early acute RV failure versus early versus late RV failure. And this is sort of a comparison of the two, Intermax versus the MCS ARC definition. And I don't want to focus on that, but I just want to think about, we're setting stage for you have a patient that's going for a VAD, you really need to think about the risk factors of RV failure up front. So in a review that we published just last year, we thought about, and I'm not going to go through this, it's just for your summary, we thought of things that are not necessarily centered on the RV. We thought also show here transthoracic echocardiographic features as well as hemodynamic features that you get from a PA catheter. And you develop an algorithm. Every institution has their own algorithm. This is the one that we published. Really the bottom line is you're suspecting RV failure or you're thinking it's coming, you're in the operating room, you're looking at afterlobe, prelobe, MAP, all of these indications, but really when you go to the bottom line, you should really be thinking about early RVAD support if you have worsening hypoperfusion, a low MAP, or problems with the LVAD flows. So MCS for RV failure. Really our options are limited, as has already been indicated. This is not what this talk is about which device to use, but it's early versus late. And there's really no consensus about how to define the population at risk. The preoperative risk assessment is key. Conservative managements, which is a little bit of voodoo, inotropes, inhaled nitric, delayed chest closure, that's really not the way to go. And I think the previous discussion has really discuss this, but insertion of a RVAD is really a number one risk factor for mortality after VADs. It can be up as high as 50 to 70%. So what's the data? If we look at the Rochester experience here, they looked at 139 patients, retrospective, 1-year survival in patients requiring LVAD with or versus BiVAD support. This is the survival curve showing you, it's a fairly old study, and their approach to biventricular support was a HeartMate 2 with a Centromag. And they thought that this strategy was actually pretty useful because they were able to wean the Centromag in 92% of their patients. Survival to discharge was not statistically significant between the two approaches, but there was a 1-year reduced survival, 87% versus 77%. The Columbia group later on looked at their HeartMate 2 Heartwear cohort, a slightly larger cohort of patients now, looking at unplanned RVAD support at the time of an LVAD implant. Here, the numbers are that only 9% of these patients actually required an RVAD. and their overall survivals are actually shown here. And I do apologize for the quality, but this is what the journal provides. So when we have to give those high, those really good DPI images, this is not a case here, unfortunately. So they don't project well. So in A, we have unplanned RVAD versus isolated LVAD. You can see quite the dramatic difference. And in B, what you see is not just the isolated isolated LVAD, but being able to wean from an RVAD as well as failure to wean. You can see the dramatic differences here. What about early versus late? Here we're getting into the nooks and crannies of this. So University of Pennsylvania published this paper, again retrospective, but a very high percentage of patients requiring BiVAD support. A, showing just LVADs, B, planned BiVADs, C, delayed BiVADs. And clearly you can see that survival to discharge, let alone long-term survival, is different if you had a planned BiVAD. So 50% of patients were able to be discharged, as opposed to those that didn't, that had a delayed BiVAD of 29% to discharge. In a larger, and this is the last data that I could find, so this is now a national cohort of patients from the STS database, much more contemporary cohort, 36,000 patients getting a VAD, and only under 1,000 patients actually requiring some sort of RVAD support or RV support at the time of LVAD implantation. And clearly the operative mortality in here is 43% of patients that get RV support is quite high. In this regression analysis here on the right, you see the patients that have been treated with VA ECMO versus an RVAD, actually there's a greater mortality risk. Acute limb ischemia is higher, obviously, and then interestingly, a higher risk of pneumonia. But then they did a little bit of a sub-analysis looking at early versus late RV support, and showed that early RV support was actually better. The odds ratio was actually 1.5, and the unadjusted mortality was only 38% if it's intraoperative offer of RVAD support versus 55% if it was done postoperatively. And it didn't matter whether it was an RVAD approach versus ECMO. So in conclusions, in my last 30 seconds, I think it's long accepted that prolonged untreated RV failure, especially at the time of an LVAD implantation, leads to adverse patient outcomes. That's not to be debated. Joyce. The data is limited to support early MCS. It's limited, but it's still some data. Joyce. The need to also consider it's really important up front to consider what is the appropriate patient. So preoperative risk of RV failure are great risk scores. Early use of MCS, Joyce. And managing these patients, I think, is critical. And there's inherent limitations. And I look forward to Joyce tearing me apart. Thank you.